Hello and welcome to this Clinical Care Options Gynecology Oncology podcast. I'm your host, Jerfis Constanzo. In today's episode, we're joined by Professor Ana Oaknin, head of the Gynecologic Cancer Program at Vall d'Hebron University Hospital in Barcelona, Spain, and Dr. Alexandra Leary, co-director in the Department of Medical Oncology and team lead in the Gynecologic Translational Research Lab at Gustave Roussy Cancer Center in Paris, France. Together, they will be discussing key clinical highlights and takeaways from studies in ovarian, endometrial, and cervical cancer that were presented at the 2024 ESMO Annual Congress, held in Barcelona, Spain. This episode is part of a larger educational program entitled Essential Updates and Experts' Perspectives in Gynecologic Malignancies, Independent 2024 Conference Congress coverage. For more information, Drs. Oaknin and Leary, along with a link to the complete program including downloadable slide set and clinical commentaries, please visit the show notes for this episode. Now let's hear what the experts have to say on data presented at ESMO 2024 for ovarian, endometrial, and cervical cancer.
Hello, my name is Ana Oaknin, and I'm very honored to share this educational event with my esteemed colleagues, Alex Leary from France. ESMO has brought a very interesting data in first-line ovarian cancer, the PRIMA data and the ATHENA data. So let me try to summarize and take you through this important data. As you recall, PRIMA ENGOT OV26 GOG 3012 is a phase 3 randomized trial that enrolled patients with newly diagnosed advanced grade ovarian cancer. All those patients must have response to previous platinum therapy, either complete response or partial response. Later on, patients were randomized to 2-to-1 to Niraparib as maintenance therapy or placebo. As you recall, the primary endpoint of this trial was PFS by BICCOLO and key secondary endpoint overall survival. Today, we are going to discuss the final overall survival data after a median follow-up of 6 years. And I would like to stress a very important point in order to properly understand this study. Firstly, the population enrolled in the PRIMA trial, although all ovarian cancer are high risk, this population are especially high risk. Why? 35% of them had a stage 4 disease at diagnosis. Almost 68% of the patients received neoadjuvant chemotherapy, and 30% of them achieved only a partial response after platinum therapy. In addition, approximately half of the patients had postoperative visible residual disease or no debulking surgery. It's very important to recall that the overall survival had a hierarchical analysis. Firstly, in the overall population were positive, then the analysis in the HRD population had an analytical value. So what have we learned? We learned that at the time of this final overall survival analysis, the author had also analyzed long-term PFS with approximately median follow-up of 6.2 years. With this extended follow-up period, they have reconfirmed the benefit of Niraparib as maintenance therapy in terms of PFS. In the overall population, they show a hazard ratio 0.66, and in HRD population, they show a hazard ratio 0.51. Very interestingly, in HRD negative, the hazard ratio was 0.67. Among all these population, I would like to highlight the outcome in the HRD. Why? Because when we look at the percentage of patients who were free of progression of death at 5 years, it was 35% for those patients receiving Niraparib and 16% for those patients receiving placebo. It means twice as many patients in the Niraparib arm were free of progression receiving Niraparib. However, what happened with the overall survival? When we look at the final overall survival with a maturity of 62%, there's no difference between both with a hazard ratio 1.01, and the median overall survival was almost equal in both arms. 46 months for Niraparib, 48 months for placebo. And recall, I said that the analysis had a hierarchical analysis. So since overall survival was not positive, the analysis of HRD was not analytical. And when we look at HRD and HRP, once again, unfortunately, there's no difference in terms of overall survival between placebo and Niraparib in any arm. So how can we explain this lack of benefit in terms of overall survival despite having a great benefit in PFS? There are several reasons that we can speculate. That means I would like to reinforce, just speculate. We don't have a reliable data to explain that. One of them is the long-term post-progression, the high number of subsequent therapy, and perhaps the high-risk patient population. I mentioned subsequent line of therapy, and indeed this is a key point because when we look at the number of patients who receive further therapy after progression to Niraparib or placebo, it was approximately 75% of patients in the placebo group, specifically in the HRD group, received any subsequent anti-cancer therapy, compared with 57% in HRD subgroup in the Niraparib arm and 68% in the overall population in the Niraparib arm. I would like to stress that in the placebo group, in the overall population, 38% of the patients received a subsequent PAR inhibitor at the time of relapse. In the HRD, 48% of the patients receive a PAR inhibitor. And very important, in addition to that, the majority of patients who received this PAR inhibitor at the relapse was a second line of therapy. So this is one of the hypotheses that we can argue to justify the lack of benefit in overall survival. And very important that there's no new safety issue in this long-term overall survival analysis. So as a kind of summary, we can say that with a median follow-up of 60.2 years, the PRIMA trial showed really reliable, clinical meaningful benefit in terms of PFS in the overall population, in the HRD population. There's no difference in the secondary endpoint of overall survival between Niraparib and placebo in the overall population, and there are no new safety regarding Niraparib. So, another important study that we should discuss is the ATHENA trial. ATHENA is one of the expected trials in first-line ovarian cancer because they analyze the role of immunotherapy. As you know, we have had several trials studying the role of immunotherapy in ovarian cancer, and unfortunately, we didn't have any positive results so far. What happened with ATHENA? Just to refresh your memory, phase 3 randomized trial for patients with newly diagnosed advanced high-grade ovarian cancer. All patients must have received previous platinum therapy, and they may have achieved either a complete response or partial response. All patients must have received primary debulking surgery. And then, as you recall, patients were randomized in a 4-4-1-1. The trial had 4 different treatment arms: Arm A, Rucaparib plus Nivolumab; Arm B, Rucaparib plus placebo; Arm C, placebo plus Nivolumab; Arm D, placebo plus placebo. So in the ESMO 2024, they presented the data of Arm A compared to Arm B, Rucaparib Nivolumab versus Rucaparib plus placebo. The primary endpoint for the ATHENA trial was PFS in the intent to treat population. Most of the patients enrolled in the ATHENA trial had a stage 3, approximately 25% stage before, that the majority of patients at the time of enrollment didn't have residual disease, and approximately 22% of the patients had BRCA mutation. And since we are talking of immunotherapy, we are analyzing the role of Nivolumab in maintenance trial. The author established the role of PD-L1, determine how many patients were enrolled having tumor with PD-L1 positive expression. And just say that approximately 45% of the population, less than 50% of the patient, had tumor PD-L1 positive. The data were a little bit disappointing because they show us adding Nivolumab to Rucaparib didn't improve the outcome that we got with Rucaparib. Very interestingly, when we look at the Kaplan-Meier curves, they show that the combined Rucaparib plus Nivolumab show a hazard ratio 1.29, no difference at all. And when we look at the median PFS in the Rucaparib plus placebo was 20 months, and Rucaparib Nivolumab 15 months. Just to refresh your memory, the data of median PFS of 20 months was the data that they have already presented. They are already published by Monk and co-author. I mean, in somehow, this data, despite not showing any benefit of adding Nivolumab to Rucaparib, it seems that they reconfirm the data of Rucaparib as monotherapy, as maintenance therapy. Interestingly, they show a forest plot to try to identify if there's any kind of subgroup that may benefit from the combination. And unfortunately, when we look at the forest plots, there's any group that seems to get any benefit from adding Nivolumab to Rucaparib. In terms of the overall survival, the data are still immature with a maturity around 46%, and there's no difference with a hazard ratio of 1.13. In terms of safety, there's no new safety signal as expected for Rucaparib and Nivolumab. Anemia, grade 3, one of the most frequent events, increased ALT, AST, and neutropenia, decreased white cells. So what was the conclusion for the ATHENA combo? The conclusion was that Nivolumab in combination with Rucaparib didn't extend the PFS benefit or Rucaparib monotherapy as first-line maintenance treatment. So the bottom line, once again, is that this trial incorporated the anti-checkpoint inhibitor in ovarian cancer didn't show any benefit. And just another important data that I would like to review with you all are the data from the PICCOLO trial. As you know very well, Mirvetuximab, an ADC targeting folate receptor alpha, is approved by FDA for those patients with platinum resistance based on the MIRASOL trial. In Europe, we are still waiting for the approval. And this trial, PICCOLO, is a single-arm trial, but it's quite interesting because they wanted to analyze the role of Mirvetuximab in those patients who may be considered not suitable for further platinum therapy by investigator, but by the book, they were still platinum sensitive because the last platinum-free interval was greater than 6 months. So patients were enrolled if they have received at least 2 prior lines of platinum therapy. All patients received the standard dose of Mirvetuximab, and the primary endpoint was overall response rate. Very interesting, the population enrolled in the PICCOLO trial was the population that we have right now in our clinic. 64% of the patients have received prior bevacizumab. And another point that I should highlight, the percentage of patients that we identify having tumor with a high folate receptor alpha, it means PS2+, it was 44%. And what about the data? Very compelling. When we look at the overall response rate, it was 52% of overall response rate. But let me tell you something. We enrolled 79 patients. Only 7 patients had progression disease. The rest of the patients got any kind of benefit, either complete or partial response or a stable disease. So the bottom line for all this PICCOLO trial is that it seems quite quite compelling having Mirvetuximab as therapy for those patients who have received 3 or more lines of therapy based on platinum therapy. In terms of safety, the safety profile was as expected, mainly, eye adverse event or GI toxicity.
Anna, thank you so much for that distillation of what was really important in ovarian cancer. Important results. I have a couple of questions for you, probably one for each of these great studies you've presented. My question on PRIMA. So we have been waiting for this OS analysis for a long time. We now have it, and in contrast to SOLO-1 and PAOLA, we weren't able to demonstrate a benefit on OS for the PARP inhibitor arm. There are plenty of reasons, and I think you really summarized them well. So I guess my question is, what impact tomorrow for you in your clinic? What is the role you feel for Niraparib for your patients in the first-line setting?
Thank you, Alice. This is the key question that we are discussing amongst all of us. My perspective is that the primary endpoint for the PRIMA trial is PFS. So the trial is clearly a positive trial. And in addition, it's true that the SOLO-1 and PAOLA-1 have shown positive outcomes in the overall survival. However, I think cross-trial comparison is always a little bit dangerous. SOLO-1 is a pure trial for BRCA mutant population. And in addition, in the SOLO-1 trial, 44% of the population were stage 3 without residual disease after primary debulking surgery. So I would say a very good population. It's true that the PAOLA-1 has a population closer to the PRIMA trial, but at the end of the day, once again, 2 different trials. So in the PAOLA, we saw that in the intent to treat population, there's no impact in overall survival of adding olaparib to bevacizumab, and we didn't see an impact on overall survival in the PRIMA trial. However, it's true that in the PAOLA-1, in the subgroup analysis of HRD, there was a positive impact. In the PRIMA, HRD is not an analytical analysis according to the hierarchical testing. I don't think that the data in overall survival change my daily practice, because I believe that the primary endpoint as PFS is a valid primary endpoint for patients with ovarian cancer according at all the reasons that I mentioned previously. So I don't think that I will modify my therapeutic approach based on this.
Great, thank you. Then you had another negative trial, so sorry. Which was the ATHENA combo. So here we go, another IO trial in ovarian cancer, which really, unfortunately, is a bit disappointing. We have a couple of trials in the first-line setting that are still waiting to read out. Do you think there's any hope some of those might be positive?
Alex, I would like to say yes. I keep my hope that this trial will be positive, but I cannot state that. I mean, every single trial that we have presented in the last years, all of them have been negative trials. So regarding the use of anti-PD-L1, anti-PD-1 agents, relapse setting, first-line setting, I don't think that immunotherapy works in ovarian cancer. What is the reason for that? I don't know either, but I don't think that the upcoming clinical trial will change this tendency. Hopefully I'm wrong, but I don't think so.
Yeah, so I think it's just important to remind our listeners that there's absolutely no rule right now in clinical practice for an immune checkpoint inhibitor in ovarian cancer.
Yeah, absolutely. And this is very important because patients still come to the office requesting immunotherapy because they have heard this in another solid tumor. And we must explain that ovarian cancer is an isolated disease where immunotherapy doesn't work.
Absolutely, absolutely. Let's get to the last trial discussed with really interesting response rates. I mean, almost all the tumors shrank, at least somewhat. Yet, the median PFS was only of the order of 6 months, which is a little disappointing given how great the response rate was. What are your thoughts on that?
Yeah, this is a very good point. What we see in the clinic and in the paper with the ADC, they are able to induce a quick reduction of the tumor size. The lasting of this reduction, I don't think is still good enough. And here in the PICCOLO trial, once again, we see that the median duration of response is around 8 months, but as you say, the median PFS is a little bit shorter. So maybe, this is as a result of some kind of resistance that we are not able to understand, or who we have not been able to identify yet, and then the patient progress much quicker than we expected. But I mean, it's true that the data are very compelling. I feel very happy to see this data, but it's also true that we should have a randomized trial to compare with the standard of care so far, that is platinum doublet. It's something that we are seeing in the near future.
Absolutely. And again, for our listeners, so Mirvetuximab, which was studied in this trial, is not yet available. But we're hoping, based on the results in the platinum-resistant setting, that this ADC might become available for folate receptor alpha high platinum-resistant ovarian cancer in the near future. All right, well, Ana, thank you so much. I'm going to now just turn quickly to endometrial cancer and cervical cancer. So what was new at ESMO this year? I'm going to discuss one trial in endometrial cancer first, and this was the Keynote B21. This is a long-awaited study evaluating the benefit of adding an immune checkpoint, here it was Pembrolizumab, to standard carbotaxol radiotherapy at the choice of the investigator for completely resected high-risk endometrial cancer. So the first time we were testing adjuvant immune checkpoint in endometrial cancer, and the study recruited patients that either had stage 1-2 high-risk histology, so stage 1-2 non-endometrioid or stage 1-2 p53 mutated, or stage 3-4 regardless of the histology. And they were randomized to carbotaxol plus radiotherapy at the choice of the investigator, or carbotaxol with radiotherapy or not, associated to pembrolizumab during carbotaxol and then as maintenance for 6 cycles every 6 weeks. So this was the first study, and I remind you that it recruited patients regardless of their molecular profile, but patients were stratified whether they were pMMR or dMMR. What are the results? In the intent to treat population, there was no significant difference. But in the dMMR population, there was nice separation of the curves, okay? Roughly a quarter of the patients enrolled in this study were dMMR, and not surprisingly, among the dMMR subgroup, adjuvant pembrolizumab improved disease-free survival compared to carbotaxol alone with or without radiotherapy. In this dMMR group, these were mainly probably stage 3, because let me remind you, it was either stage 1-2 with bad histology or p53 mutated. So dMMRs were probably mainly the stage 3-4. In this population, were only 8 relapse events in the Pembro group versus 25 relapse events in the placebo group. So I think this is a first study showing strong evidence that in completely resected high-risk dMMR endometrial cancer, there's a benefit to adding an immune checkpoint. There is, however, absolutely no benefit to adjuvant immune checkpoints in eMMR or MMR competent. There's no benefit of adding an immune checkpoint to standard adjuvant chemo-RT. So I think that's an important message. I don't know what your thoughts were on this study, Ana.
Alex, this is a very important trial. For me, the trial has 2 very important messages. One of them is that you have really stressed very well. There's no benefit for those patients whose tumor are pMMR as adjuvant therapy. I think it's quite important to make the difference between adjuvant therapy and first line. Adjuvant therapy in endometrial cancer is those patients who have not evidence of disease after surgery. And then the another important message is the relevance of IO in the dMMR subgroup. In the dMMR subgroup with a hazard ratio 0.31, they show the magnitude of the benefit of adding immunotherapy to chemotherapy as soon as possible. In this case, as the opposite to pMMR for those patients who have not evidence of disease after surgery. So I think this data reinforce the value of immunotherapy in this group. When you look at the number of events in the Pembro arm, curve is absolutely flat. So I think the B21 provide very important information for our daily practice.
Absolutely. And let's remember that the B21, because they had no residual disease, we are going with curative intent. So this great flattening of the curve in the DMMR by adding pembrolizumab to standard adjuvant chemotherapy really means we're curing more of these patients. And I think that's really great news. And the last study I was going to discuss was in cervical cancer. So insofar as we told you that immune checkpoints did nothing in ovarian cancer, clearly we've just shown you yet again where they might have a role in endometrial cancer, and cervical cancer is another good candidate to immune checkpoint inhibitors. And the data we had at ESMO at the plenary here were the results of the Keynote A18 trial. Let me remind you, this was a study we already had preliminary results on PFS benefit for patients with locally advanced cervical cancer, stage 1B, 2, 2B, or 3 to 4A, addition of pembrolizumab during chemo-RT, followed by pembrolizumab as a maintenance for 15 cycles every 6 weeks, significantly improved progression-free survival for patients with locally advanced cervical cancer. The updated results we got this year were overall survival benefit, because again here we're in the curative setting. It's really important to see if the addition of an immune checkpoint may not only improve PFS, but also improve overall survival. And basically the take-home message for the updated results on overall survival is that they are positive, okay? And the intent to treat, we had a significant improvement in overall survival, okay? The survival was not reached in both groups, but hazard ratio was 0.67, the highly significant P. Okay, so that's really very good news. The addition of pembrolizumab for locally advanced cervical cancer significantly improved not only PFS, but also overall survival. When they looked at benefit in pre-specified subgroups, we saw the same trend that we had seen in the progression-free survival, that the benefit of adding pembrolizumab is really greatest in the stage 3 to 4A. Okay, less benefit in the 1B, 2 to 2B, and for now the approvals are for stage 3 to 4A. So in conclusion, we have 2 studies that bring important information on the role of immune checkpoint inhibitors in endometrial cancer and completely resected dMMR endometrial cancer. There's a benefit to adding an immune checkpoint. We knew it was already the case in the advanced metastatic setting when disease is placed, but here B21 shows that when you're in the curative setting, there's no disease left postoperatively, there's a benefit to adding an immune checkpoint to your standard chemo-RT. In cervical cancer, we finally have great OS data to support the addition of pembrolizumab to standard chemo-RT for locally advanced cervical cancers, especially stage 3 to 4A. These are 2 practice-changing trials.
Alex, thank you so much for this excellent summary. While you were delivering the presentation in the cervical cancer, I was thinking of how this trial had changed the standard of care that we have had for more than 20 years. So, but my question to you is about the FDA approval. FDA has approval the indication only for stage 3 to 4. FIGO 24, please. Let me reiterate that is FIGO 24. That is not the same FIGO 28.
Yep.
Based on the Forest Plus, it has a ratio 0.57. However, what are your thoughts of not having the approval for patients with 2B FIGO 2014 based on the subgroup analysis? Do you feel comfortable ruling out those patients of having Pembro as part of the locally advanced therapy?
Yeah, so very good point. I don't think approval should be based on forest plots. So that's my first answer to your question. That being said, the benefit is greatest there. I think maybe where the approval may have suffered from previous negative trial, right? I think that if we had not had a negative trial, this is the CALA trial, maybe it wouldn't have done the same thing, because we know that, you know, some of our patients with stage 2B are very high risk, and we really want to do everything to cure them, because we know that once we miss it, we're not going to, you know, be able to salvage them. But beyond being a forest plot, this was a stratification factor, okay? And we know that we get approvals in subgroups that were based on stratification factors, okay? We've done it in PALA, we've done it in other studies. So I think we don't know enough to say with confidence what the benefit is in 1B, 2, 2B. I'm not saying it's not there. I think we don't have the same level of confidence.
Yeah, this is true. I mean, this is also one of my thought. I mean, waiting for the EMA approval. I don't know yet. EMA will follow the FDA indication, or finally they will make the decision approve the therapeutic, the Pembro for all comers. So let's see what happens. But what is true, this is the first time in the last 25 years that we see an improvement of 12% in the overall survival in 3 years. So great. So thank you so much for this kind distillation.
And then I'd just like to leave a sentence on the future. And Ana, you have greatly contributed to this future, which is there were great presentations. We're not going to discuss them on ADCs in gynae cancers, so antibody drug conjugates, in ovarian and endometrial cancer, and cervical cancer, and there's just a huge wave of these coming, and they all showed really encouraging results at ESMO with response rates of the order of 30 to 40%. So it's just they're not leading to approvals yet, but keep your eye on that because I think that might be the wave for the future. On that note, I'd like to thank everybody for listening, and thank you so much for being here with me. As usual, it's a pleasure to discuss the results with you, and we wish everybody a very nice day.
Thank you, Dr. Oaknin and Dr. Leary, and thanks to you, the listeners, for joining us. As a reminder, to view the full program, essential updates, and expert perspectives in gynecologic malignancies, independent 2024 Conference Congress coverage, and to download a slide set associated with the discussion, please click the link in the show notes. As always, thanks for listening.